Check and see if it's not. I got a thumb drive in my bag.
That one. And then here's a clicker. Okay. Want to use it? Make sure they turned it. Yes, it is. Then move you forward. That should move you back.
Great. Thank you very much.
Try it just to make sure.
There you go.
Cool.
Good afternoon. We're going to go ahead and get started with our next session. I would like to introduce Chuck Christian. He has a 40-plus years worth of experience in healthcare, including 27 years as a healthcare CIO. Currently, he works as Vice President for Technology and Engagement for the Indiana Health Information Exchange in Indianapolis, Indiana. He is past chair of the HIMSS Board of Directors and current chair of CHIME Board of Directors. It's my honor as a current member of the Indiana HIMSS Board of Directors to introduce Mr. Chuck Christian.
Thank you much. Actually, since I gave him my bio, I'm now the past chair of CHIME, but I'm not the chair of the CHIME Foundation this year. So thanks very much for, I was one of the first years that they had this conference. They asked me to speak, and they keep asking me to come back and speak again. I'm not sure why. So I spent 25 years in Southern Indiana. I'm originally from Alabama, so if I say something you don't understand, throw it in the hand and wave at me, and I'll be happy, because I will throw some Southern terms at you. So if you don't understand, let me know. We'll do it. The other thing is, I'm going to talk about 45 minutes or so, and if you have a question during the conversation, if there's something you want to ask about, hopefully I will be provocative enough to get you to ask a question. For you, if you want to go over questions to the end, I'm going to save about 10 or 15 minutes for questions then. So, does anybody know what the background on this slide is? Come on, anybody been to Colorado lately? It's a stand of aspen trees. Now, you might ask, what the hell is aspen trees? That's a Southern term. Has got to do with interoperability. So what's the unique feature of aspens? A single grove are all connected. And there are those, it's typically a clonal colony. There's actually a stand of aspen called Pendo in Colorado that they believe is over 80,000 years old. And I didn't help you all, I think I was there when the first sprouting came out of the ground. So the reason for that is because all these trees are interconnected. How many of you have seen the movie Avatar? Okay, so you know what Avatar is, but you don't know what aspens are? Okay. What was the interesting thing about Avatar? The forest and everything was connected. So this is what we're going to talk a little bit about interoperability. So next graphic is unicorns. What does unicorns have to do with interoperability? Come on, folks. I know it's after lunch. I know the news have a big dessert. I had some sugar, so I'm okay. I'm sorry. It's a fantasy. Okay. There is a lot of definitions about unicorns. You see some unicorns that have wings. That's Pegasus with a horn. But the really interesting thing is about health information exchange, interoperability. There are a lot of definitions about it. If you've seen one, you've seen one. So this is what I call this thing that we are talking about, interoperability, the search of the imagined. Now, this morning we heard Kim talk about the need for the records of patients to be interoperable and the information to be moving from one place to the next. You heard Neer talk about that we're not really seeing a lot of benefit from interoperability because we just haven't got to that version of interoperability yet. And so I'm not going to tell you about what we're doing in Indiana. If you don't know, you have to tell me after, but this is kind of a commercial before our exchange. The other thing is, you'll find out in my conversation, I am a shy guy. And I will be more than willing to share my opinions about interoperability and a variety of other topics. The other thing you need to know about me is I raised $4. That's why I have no hair and no money. So I don't know which was better training, raising $4 or being a healthcare CIO. Because both require a lot of patience and money. So let's talk a little bit about interoperability. I'm going to give you some examples. What are these? Legos. They're absolutely great things. And so what does Legos have to do with interoperability? They're all shapes, colors, sizes, but what do they have? They have some standard ways they connect with each other. And I will tell you, you can build just about anything with Legos. I watched a YouTube video, I need to get a life, about a guy who actually used Legos to create a concrete mold for concrete nesting tables. They turned out really great. I haven't made any yet, I don't have that many Legos. And over the Christmas break, my granddaughter spent the Christmas holidays with us, and we actually built a Millennium Falcon. And that was pretty cool. There were some custom parts in it, but the grand majority was just squares with holes and pegs. So now once we get the standard about how things are going to connect together, we have to worry about the vocabulary. And I really like this graphic because it uses the word plant, just like the word plane. And there's a few other ones out there I could talk about a little bit. We have to, you heard Near talk a little bit about, we need to make sure that when we're talking about a lab test in this facility, we're talking about the lab test in this same lab test, so we can put the information together. The vocabulary we use and the nomenclature is extremely important, particularly if you're from the South, because things mean things different down there than they do up here. So now that we've got the vocabulary nailed down, now we have to worry about how are we going to move that information around. It looks like the internet. There was a lot of talks some time ago about Internet 2.0, which is just going to be for healthcare information. But it looks like the encryption technology has got to the point now that we can actually use the internet for transport of PHI. I'm not sure that's the safest thing on the planet. How many of you have Anthem Blue Cross insurance in Indiana? Your information was breached a couple of years ago. I was one of those as well. So far, Anthem still is the winner. They're at the top of the pyramid of the most records breached. So that wasn't done through the internet. So last but not least, this is what I kind of look at as interoperability. All the gears and cogs fit together, everything flows without a lot of friction. Now you know the first thing I showed you other than Aspen was unicorns. Because it doesn't exist today, but this is where we're working toward. So how many of you know what this is? What's that? Railroad tracks. How many of you knew exactly what the standard gauge is? 56 and 56.5 inches wide. That's the standard gauge. Every railroad track in the United States that the public trains run on and CSX runs on is on that gauge. But they weren't always like that. In the early 1800s, when railroads began, they were all kinds of different gauges, 24 inches, 60 inches. I really like the one on the bottom, the 36 and 56. That's kind of like HO7. It's kind of a standard, but yet it's not. But you couldn't take a train that was set up for a 24-inch gauge and run it on a track that was set up for 56.5 or 60. Now, one would think the wider you get, the better, but guess what? The wider the train is, the bigger tunnel you have to get in order to, bore a hole through the mountain. So, railroads were designed originally to do transportation of people and material in local and regional areas. Kind of sounds like health information exchange, doesn't it? Most health information exchanges, except for a few, are based upon regional referral patterns and how care is delivered in that area, and the reason for those healthcare providers to share information with each other. So do you know why that all of a sudden, after about 60 years, the railroad decided, you know, we need one gauge, we need one standard? Well, it's called economies of scale. The people that started buying up the various local and regional railroads decided, man, I really would like to run my train on that track across state lines rather than have to offload the freight and load it again. And so they went to standardize the tracks. And so, another thing, I had a friend of mine that has listened to this presentation, and we talk about railroad tracks and standardization. So he sent me a thing that he got off the internet. That must be true if it came from the internet. Is do you know where 56.5 inches came from? How that gauge came about? Well, interesting enough, it's the exact width of the wagon wheels of the prairie schooners that went across the west. It was also the exact width of the Roman chariots. Believe it or not, you know how that was come up with? That's the exact width of two horses walking side by side. Now, I don't know if it's true or not, it's on the internet, so it don't be true. So, here's another example of interoperability. How many cell phones are in this room? Everybody has a cell phone. Not everybody's on social media, but everybody has a cell phone. The dial tone that you get on the cell phone is the same dial tone that you can get anywhere in the world. And why is that? Called standards. Alexander Graham Bell did not envision that we would have cell phones. Now, Nikola Tesla did, even though he was in the 1800s and early 1900s as well. But the really interesting thing is it doesn't make any difference which one of these form factors you use. You can talk to the person at the other end if you know their number. It's like that's the same thing with a piece of mail. You can send a piece of mail anywhere in the world if you know their address. But it takes time. What do we have to have in order to make a phone call to somebody you don't know? You have to have a directory. And do you think there's a directory for every healthcare provider in this country that exists today? No. If you are a hospital and you have a patient that's going to have care at a post-discharge visit, you will have to go find out, probably pick up the phone and call that provider, and what is your direct address so I can send you a transition of care document, unless there's some other technology involved. But wait for it. Hopefully soon we won't have to do that either. So I'll give you one more example of interoperability. Now, Near said this morning that it was in the 70s that we were able to take out money anywhere we wanted to. Well, I'll disagree with him. He's got more education than I do, but I have the internet. And I believe everything that's on the internet. Is that it was in 1967 is when, according to one version of the internet history, is when the ATMs appeared on the scene. This was in London. But there was another version of this history that says the ATM was actually invented in the United States. I'll let those people duke it out, because the timing is about the same. The other thing is that these ATMs, they do not run on the internet. They run on proprietary but very private networks. And it wasn't until the 90s that all those networks converged. So a ATM in London could talk to an ATM in Cincinnati. And the standards that they use are extremely strict. That drives me absolutely insane. This is another one of those opinions that you'll hear from me. For somebody to compare the healthcare system to the banking industry and say we should be able to move information just as easy as we can go get money out of our bank. And I said, well, guess what, folks? The banking industry has something that we don't have. They have defined networks of how they're going to communicate over. And oh, by the way, that if I want to take money out of my bank account, what do I have that identifies me with that money? My bank account number. What is my bank account? They have a routing number. So it knows exactly what bank it's in, it knows what account it is, so it knows who I am. We don't have that in healthcare. The other thing is the very limited pieces of information that the banking industry has to move around. They move in, one, you have to count, yes you do. If you want to take out $100, does he have $100 in the account? Yes he does, okay, give it to him. We're going to take that transaction. If healthcare information was that easy, we'd be doing it already. It's not. Because today, folks, we can't ensure that the lab result that you're getting at CBC in Evansville, Indiana is the same kind of lab result you're going to get for a CBC in Fort Wayne, Indiana. Or even to break it down a little bit more, the same thing done at St. Mary's as you do at Deaconess. There's some normalization. How many of you have heard of LOIN? LOIN. It's a nomenclature that is a standard naming convention for lab test. It's called LOIN. And so you know who invented that? A little place up the street called the British Street Institute. You know why they did it? Because they were taking information from all these disparate healthcare systems, and they could not put it all together. So they came up with a way to codify it. This is part of the standards that now Neil was talking about this morning. We have to have more of those, and each and every one of us have to follow it strictly. If we're going to exchange information as readily as moving data from our bank to an ATM, we're going to have those things. Am I getting a little preachy? Yeah. Keith's sitting back there. He'll throw something at me. Now, the other thing you'll find that there has to be a balance, and we've talked a little bit about this. The social media that John was talking about just worries the crap out of me, because now if there are three of you who have are not on social media, I just want to know how many are dropping their social media accounts once they're using these comments. I think I'm very careful. I'll share this story with it. It's a little embarrassing, but not for me. My daughter is a social worker, and when she was at IU, there was two young men that got recommended to the Kelley School of Business. That's not easy to do. And you typically have to go for a year or two, then you get into the Kelley School of Business, and so you either you're really smart or really good at what you're doing. Well, they posted on social media, Facebook one day, and I happened to be walking past Katie's laptop and I saw this, and there's two young men, and the only piece of clothing they had on was a tube sock. Well, they shared a pair of tube socks. It wasn't the same one. And I told Grady, I said, do you know those boys? Yeah. She told me, I said, you better call them and come take that picture now. I said, because it may be too late. And she said, too late? I said, they're in Kelley School of Business. Their next employer, where they have an MBA or not, is going to see that picture and go, what kind of idiot poses in a tube sock? Do I want him representing my company? So it's absolutely, what John said is absolutely true, is we have to be very careful. So we have to make sure we have this balance between access and security. I remember a conversation I was having with a group of physicians at Good Samaritan right up the road in Vincennes, where I was, and talking about the options of data access when we're putting in the first EMR. I said, there's a variety of ways we can do it. Well, how would you like to do it? Well, I had a couple of physicians say, well, I want to make sure that whoever enters the information on my patients I can see. But I don't want anybody to be able to see what I am. And I thought for a minute, and I said, did you know what you just said? I said, every physician in this room says that, nobody will see anything. So you might as well just keep it on 3x5 index cards. And so there truly is a balance that we have to come up with access and security. We have HIPAA. How many of you think that HIPAA prevents stupid? It doesn't. There are many people that have lost their jobs because even though they're told, don't believe that celebrity record, they'll do it anyway. It's kind of like my kids, don't put your hand on the iron, it's hot, you'll get burnt. I don't believe it. So sometimes you just have to let people do stupid things. But the thing about it is that how many of you know how much a credit card record is worth in the black market? I got it on the internet, folks. That's where I got all my information. About 50 cents. How much is a health record worth in the black market? $5 to $50. Because there's so much information in a health record that you can do much more interesting things. Interesting is in a bad word. bad way about how you can use that information to spoof the identity of that patient. It's worse than having your name, address, telephone number, and the social security number. So you're going to hear me talk a little bit about this thing, and this is the thing that I actually did an article for Health Ed magazine not long ago, but last week, on this topic of things that's called exchange and interoperability. Do you think they're the same thing? Come on, you're among friends. No, they're not. That's Chuck's opinion, okay? And then this is the thing that bothers me a little bit about the EMR vendors, and is even when I was a healthcare CIO, just because I work for information exchange, I'm not biased, but I know what. When I was, and I spent 2.5 years in Georgia, and the very first thing I did when I got there, other than moving my stuff in my office, is I went across town to the other health system, about the same size, about 400 beds apiece. And we split the medical staff of Columbus, Georgia, in about half went there, the other half went there. Very few went to both places. But we didn't share any information. They ran CDs about it, we ran testing, and I take 70 cards if anybody wants to send me one. But we didn't share information. But we also had another interesting entity in that area called Fort Benning, Georgia, and Mark Army Hospital. And they do funny things at Fort Benning. They jump out of airplanes, they have tanks, and all that kind of stuff. But guess what? 2 services of ours they're going to use a lot of? Spine surgeons, knee surgeons, and heart surgeons. So everybody might push me on an airplane because I wouldn't jump on my own. So it was really, but the really interesting thing is we couldn't share information with Fort Benning about their health system. The DOD was a little funny about that, but they have a solution that they installed for all of DOD called Relay Health. And so that's what the other health system at St. Francis, we all got on that platform. And as I was leaving Columbus to come back to Indiana, we had it where it didn't make any difference where that patient had care. They had one portal, and everybody could see the information appropriately. That just started to happen now. Both CIOs of both organizations and both CEOs of both organizations left. Where it is today, I don't know. I need to call my friend at Fort Benning and see if they've taken it any further. But we were doing interoperability. We weren't doing just exchanging data. We were moving stuff around. How many of you have heard about the things called CCDAs? Okay, I'm going to give you, for all the students on this side of the room, because that's where y'all all sat. You knew that, didn't you? A CCDA is a continuity of care document architecture. It is a standard clinical document that is required by meaningful use to be shared on a transition of care from one transition of care to the next. That means if you're discharged from the hospital and you're transitioning to either a home health care agency or a rehab facility or your physician, that hospital is required by federal law on a certain percentage of time to send a transition of care document in this format. How many of you believe that format is the same of all transition of care documents that are sent out of all EMRs? It's a standard. Well, maybe it's a guideline. No. The other interesting thing is that even the one that the federal government says you can have 2 versions, and one cannot consume the other. And so the EMR vendors struggle with this, and they still struggle with it today, because within that continuity of care document is patient demographics, allergies, medications, immunizations, and lab results, and radiology results, and some of these things are 60, 70, 80 pages long. We absolutely burnt up fax machines in the physician practices, and they said, stop. Do not send this to us. We're not using it. We don't want it. If you're going to continue to send this to us, you're going to have to buy us paper and fax machines and staff to file stuff. And even the ones that had fax stuff in their office that was automatically connected to their EMR, they still had to staff up in order to figure out how to index this stuff and move it into the medical record. They weren't using it. They didn't find it valuable. So we were exchanging information with them, but it had no value. And so what we were wanting to do, the next step level we wanted to do is take that information, blow it apart, take the lab results and move it into their lab section of the EMR. take the radiology results or this intentional result and move it into their record so they can actually search it. It would be meaningful and useful for them. So to me, that's the difference between exchange and interoperability. They are not the same thing. And the unfortunate part about meaningful use, now meaningful use did some really great things for us and did some not so great things for us. When meaningful use came out, how many health information exchanges were in this country? Got them on one hand. And then they threw a bunch of money out of the HITECH Act and ARA, the Recovery Act, at states to stand up health information exchanges. There wasn't a lot of expertise on how to do that. The EMR vendors didn't know how to address interoperability, and so the grand majority of those that were stood up failed. They're still failing today because it cost a significant amount of money to run these things, and it's a fixed cost. And so, but we're just, as you heard Near talk about it this morning, we're just getting to the point. You know, it's kind of like the field of dreams. If you build it, they will come. So we're just getting to the point now we have infrastructure in place to actually see the value of this stuff. And so now is a good segue into my next slide. I used the V word. I did not get this off the internet. Man, y'all going to sleep? Thank you. Okay. No, the value of interoperability. One of the things that I've always been amazed about what the information exchanges that are actually doing really good work were designed around a clinical encounter of where the patient's clinical information needs to be. Many of the ones that were designed around financial transactions, Medicaid populations, didn't go anywhere because the only people that were getting value out of it was kind of the states. But the clinicians who are actually providing care to the patients, when they're starting to get value out of it, they're asking for more. We've had a lot of conversations with physicians all over the country as I've gone around and talked to them about, here's what I want. At first, I wanted access to the information. That's really great, but now that I can get to it in some locations, I don't want to have to fire another web page and go look at that patient. I don't have time to do that. In talking with some ER physicians that are doing about 85 to 90,000 ER visits a year, it's a pretty busy place on Friday night. They have just enough time to take care of the patients and do a really good job of how to provide high quality care. They don't have time every time that they see a patient to go fire another browser, go log in, go look at that patient and see what they can find. They want the information presented to them as part of their workflow. And that's a really key point, is this thing called interoperability. I believe it has to take into consideration for data integrity, the quality of the data, and the clinician's workflow. I mean, how many of you are going to be nurses? Great. My wife's a nurse. She's retired. I wish I was. I love what I do. One of the interesting things years ago when I was watching my daughter was the trainer for all the sports, is, and remember the flip cell phones? Some of y'all may be too young to remember the flip cell phones. That had 3 letters for every, each key had 3 letters. I'm sitting in the stands watching the Vincennes Lincoln basketball game, and I'm watching one of the young ladies who was one of the managers of the boys basketball team. In her left hand, she had a PDA. In that left hand, what she was doing, she was keeping track of the rebounds, fouls, assists, points, and stuff that the boys would get. What was in this hand? Her cell phone. And she was texting using 1 key for 3 letters, and she was flying with that thing. And I looked at my wife and I said, oh my God, that's the nurse of the future. And she said, what do you mean? I said, we're going to be moving to bedside documentation, where the nurse is going to be interviewing the patient and doing admission assessment, they're going to be entering information. Wouldn't it be great if she could keep eye contact with that patient and do it with his hand? There is nobody on the EMR vendor planet that's doing that today. We're still having to use, how many of you are being trained with full-blown keyboards at the bedside? We tried touch screens for a while. Man, that worked really good. No. So, Clinical information at the bedside for interoperability is extremely important. You also heard Kim talk about this morning about care coordination. I have a good friend of mine who was the CIO of a health system in Colorado. His son had cancer. They lived in Fort Collins, and they wanted his son to come down to Denver for all his treatment. He said no. You know, it's a 3-hour drive. We're not going to make that trip 4 or 5 times a week. And so he says, everything you need is interoperable. We can move the data anywhere it needs to be. So he did that. And the boy did really well. He's in college today. And all the data they needed to provide care, all the pediatric oncology dosing and stuff was done in Fort Collins. They got the information from the pediatric hospital in Denver. Everything worked beautifully. 10 years later, his daughter comes up with a very interesting cardiac problem in Georgia. They moved to Georgia. And they're managing her care with a 3-ring binder. And I can believe it. And that's really, you know, in this day and age, we shouldn't have to do that. It's because they're having to move that information from care provider to care provider to making sure that they were engaged with the care and having the most appropriate information. So care coordination is extremely important. You heard John talk, you heard Near talk a little bit about bundle reimbursement, the hot salsa related to the Affordable Care, the Affordable Care Act, ACOs, and those type of things. We're going to be paid based upon what we do and how well we can coordinate among those things. Healthcare is so siloed, it's not even funny. It's so siloed even in the hospital. How many of you in your hospitals have running a different EMR system in the emergency room than you are in the inpatient suite? I am so sorry, because I did that in since I did it in Georgia, and it makes it the transition of that patient from the most critical acute care place, and they're typically going to critical care or one of the high-end surgery areas. Those nurses struggle greatly to get that information. And it all has to be re-entered, which is just insane. So that's Chuck's opinion about being insane. So being married to a nurse, you kind of get a little bit different perspective on it. The other thing is that you heard a little bit more about this morning was population health. This is something that's just coming into view. And it's about taking care of populations of individuals, but right now it's predicated not upon disease process, but it's predicated upon financial rewards or penalties if you can't take care of those. Medicare is doing a lot of that with their defined patient populations and being able to coordinate that care wherever that care takes place. But guess what the health system is doing at the same time is we're trying to figure out how to provide care in a very normal fashion where you have a staff physician practice, you have a hospital, and that's kind of where all the care takes place. Healthcare is changing. We have things called minute clinics. We have telemedicine. We now have, it's really kind of interesting. When I got into healthcare 40-something years ago, I started when I was 2. Y'all are still awake a little bit. Is that most of healthcare took place at the hospital physician practice. But guess what? We have post-acute care. We have home care. We have visiting nurses. We have all kinds of other things. That information is not following that patient. But yet, when that patient presents herself in the physician's office, that physician is expected to know what's going on with that patient. It's because they don't. Guess who is the historian? The patient. Well, how many of you, when you have something acute going on, and you're in the back of your mind, you don't know what that lump or that pain or whatever it is, you can think through a good clinical history that's going to be relevant to that patient, to that physician at that time. I'm a clinician. I was an X-ray tech for 14 years. I'm married to a nurse. I know how important that is. But I will tell you, about 17 years ago, I had a heart attack sitting in my desk in Good Samaritan Hospital. Well, I shouldn't say that. I was having the heart attack because I was smoking a cigarette walking around the building, which was actually the last cigarette I ever smoked. But when I got to the emergency room, when they started asking me my history, the only thing I could do was cry because I was hurting so bad, and I was afraid I was going to die. Thankfully, my wife was 8 minutes away. She got here, she could give them my clinical history and my family history. And they still thought I was having a gallbladder attack. I'll tell you that story real quick. I was on the table, I was prepped, they were fixing to sedate me, and there was another cardiologist came in and says, I got a guy that's 44, I was 44. And he's crashing in the emergency room. I've got to have the table. They moved me out, parked me in the hallway. They brought him, put him on the table, he was having a gallbladder attack. Yeah, I wish I had arteries like his. They were like hose pipes. You know what a hose pipe is? It's a garden hose. That's what we call rubber hoses in Alabama, hose pipes. I had a 98% occlusion in my right posterior artery in my heart. It should have killed me, and it didn't. So, having that information, the family history and stuff, would have been really great, but didn't have it. The last ones on here, the financial research analytics, is the other thing you heard Near talk about this morning, and I really appreciate how they kind of set up my discussions, and as Kim did, and many of the things from the patient's point of view. Because really and truly, if we are not in healthcare, if we're not looking at everything we're doing from the patient's point of view, I think we miss the point. Because that's what we exist to do. Our jobs are not to produce great bills, and our jobs are not to deliver medications except to our patient population. We are in this business, and we are called into this business because we are here to take care of the people that we take care of. We need to keep that patient focused in the middle of everything that we do. I think it's extremely important, so I really appreciate Kim's comments this morning to kind of help me reset and about what we do. So let's talk a little bit about approaches of interoperability. And you're going to hear a few of my opinions come out during this point in time. How many of you know anything at all about health information exchange and how it works? Well, guess what? More hands are going to come up when I get done. But that's another southern term. Get done is when you're finished. So there are things called private HIEs. How many of your organizations are connected to private HIEs? Let me ask the question a different way. And I had a conversation with an individual at lunch today. How many of you are running disparate systems in your organizations that have point-to-point ADT and result interfaces to those other applications and systems? You're running a private HIE. Because that is health information exchange, and you're moving using standard HL7 transactions. Every organization I know on the planet, until those started installing Epic, and even those large Epic installations, anybody from Deacon is here? When Todd Richardson, you remember Todd? When he was your CIO, Tom and I have known each other for a long time, and he showed me the diagram. Actually, he and I were speaking at this conference at the same time years ago. He showed me the diagram of the integration that's taking place at the Deacon's campus. I don't know if it's the same today. And I said, I can take that one in mind and hold side by side. They look almost identical because of all the various systems that were being used for the ancillary stuff. You're having to use an interface engine to create that integration. So y'all are all running private HIEs, whether you believe so or not. That's really, I think everybody is trying to get to that single record where everybody's using the same information, and that's the premise that Epic is built upon, the premise that Cerner is built upon, and others. And it's really, McKesson's trying to get their repair guy, but I don't know if they'll ever make it or not, but hopefully there's somebody from McKesson in the room. Anyway, so how many of you are connected to regional HIEs, like the Indiana Health Information Exchange? Okay. We call it regional, even though it covers almost the entire state of Indiana. It is in the Indiana region. We're not connected to anything beyond the boundaries of Indiana because during the HITECH Act and ARA, the government created these invisible boundaries called state borders. It wasn't meant to be fun. No. So the other thing that creates these invisible borders are the privacy laws in the different states. It makes it very difficult to share that information across state lines when the privacy laws, when you have, I'll use Illinois as an example. I don't know if this is true or not, but Illinois may be an opt-out state, and Indiana may be an opt-in state. I don't know if Indiana is actually an opt-out state. That means the patients, when it comes to your organization, if they want to be part of the health information exchange and have their information shared, they have to specifically say, I want in. If it's an opt-in state. If it's an opt-out state, you're already in unless you say I want out. So it makes it very difficult to share that information. Now, how many of you are running Epic in your organization? Well, you know what this phrase means, don't you? Care everywhere. When you install Epic, you're part of the phone book. You can prevent your organization from querying another Epic installation, but you can't prevent them from querying you. And what that means is that if you have a common patient, if you want to go out and see if they've had care in your phone book, it'll come back and bring you a link to a CCDA, and it will bring that back to you that your clinician has to read. In my humble opinion, that is not interoperability, that is data exchange. They are different. So that means I'll use Kansas City because I had a long conversation with friends of mine in Kansas City, and there are multiple, believe it or not, maybe it was St. Louis, multiple instances of Epic. They're not in the same MRN pool. So they'll go out and query each other, and the patient has had service at any of the 6 facilities. It can bring back 5 CCDAs that the clinicians have to look at individually, and they have to figure out if they're going to use that. Well, a lot of the physicians I've talked to don't have the time to go out and look at all these things. They would love to have one today. If they have to go look at, give me one. The problem is that we don't have the standards and the nomenclature put in place yet, or so you can bring all that information and make it discernible into one record yet. But I have faith that we're going to get there. How many of you have heard about the eHealth Exchange? Okay. This was actually the national highway that ONC, the Office of the National Coordinator, when Dr. Redder was there, was going to create. This became it's really not a technology, it's not a piece of software, it's a legal framework about how data is going to be shared. How many of your organizations share data with the VA? Or the SSA, Social Security Administration? That eHealth Exchange is the framework that information is shared. In Indiana, the Indiana Health Information Exchange, we can be and we are queried by any VA facility in the country. There's 1,100 of them. They can query us and we give them back information because we are onboarded to the Health Information Exchange. And this is how for our customers, we share information with the Social Security Administration related to disability claims and requests. How many of you are running Cerner or Athena Health or Allscripts? Well, Commonwealth is the platform. There's another one that Cerner has that I didn't put on the slide because Commonwealth seems to have taken its place. Commonwealth is very similar to Care Everywhere, and the fact is, but it's a little different. It's embedded into the software, and if you get registered and say at a Cerner facility that's onboarded to Commonwealth, it will automatically query the data locator services out there and automatically put a link in the EMR that you can go take a look at it. But once again, if they find that patient has had care in 12 or 14 different places, you're getting 12 or 14 different documents out there. So I was on a webinar yesterday with Class. How many of you know Class? Man, I'm giving you a whole lot of new terms, aren't I? Class is basically consumer reports for the health information technology space. Class stands for the first letter of the 4 guys that started it: Kent, Adam, Lawrence, and Scott. Not that y'all really need to know that, that's where the Class came up with. Yesterday, what Ken said about Commonwealth, they go out and they interview people who are actually using the technology. They listen to the vendors, but they don't include any of their marketing or their boilerplate stuff in things that they publish in their research. They talk to people who actually use it. And so one of the things that Ken said yesterday I found really interesting is that if you look at the literature, when the CEO of Commonwealth now sits on the policy committee for the ONC, when he talks about it, they've got thousands, tens of thousands of organizations that are signed on to Commonwealth. But when Ken went and asked for even that list of people that I could go talk to, we were talking 10 or 20, they couldn't get it because they couldn't find anybody that was using it. So they may be on board because they have the software installed, but nobody is using it. And that's not my opinion, that's what Kent said yesterday. And then how many of you know about care equality, or this thing called the Sequoia Project? Okay, kind of, sort of? Well, good, that's about anything anybody knows. So rather than trying to explain what care equality is, I've spent a lot of time talking to the folks that designed this, and I work in health information exchange, and I will tell you, I'm still a little fuzzy. But I'll give you a picture. I think it's worth 1,000 words. Is what care equality is basically designed to do is take all 4 of these domains, and HIE can be private or public, and make a framework that they can all talk together. It's kind of like a common language. How many of you watch Star Wars? Okay. They all have different languages, but they have a common language they can communicate with. And that's exactly, once again, this is not a technology, it's not a platform, it's a legal framework in order to share that information. So if I share your information with a health information exchange or a Commonwealth, or share your information from a Commonwealth request from Florida, I'm not going to run afoul of the state or federal laws around that. We have a legal framework that we've agreed to how we're going to share that information. So there's some barriers of interoperability, and I'm going to kind of blow through those pretty quickly because I think y'all have heard a little bit about this, is there are still those organizations that believe their data has strategic value, and I was going to change that word to be competitive value, but I think strategic is probably a little bit softer term. The other thing is there's a cost associated with it. There is not an EMR vendor on the planet that is going to hook you up to anything for free. When was the last time your EMR vendor gave you the software? Ain't gonna happen. And it's tens of thousands of dollars to do this. Then the other thing is the technology and the infrastructure. I mean, it costs money. It still costs money to do this, but there's also some lack of standards around the technology. HL7 is a great example of a standard, but it's really truly more like a guideline because, there is a negotiation that takes place with every HL7 interface I've ever been involved in between the vendor and the hospital about where things are going to go in the transaction, what you call a patient account number, how they call an account number, some of us may call it a session number. You got to figure out the nomenclature of this thing because it's not standard. And then we have this thing called positive patient identification. On the average, in your organizations, what do you think your patient medical record duplication rates are? On the average. I will share with you, when we did the studies at Good Sam, Wendy Mansions, the Director of Medical Records, the Director of HIM, Health Information Management, she hit me about it. She heard me say medical records. Our duplication rate was 26 to 7%, but the real duplication rate was between 12 and 15%. When I got to Georgia, we were running 4 EMRs, and we had an EMPI, Enterprise Master Patient Index. And we had this massive trouble with duplication. So I was sitting up in Atlanta talking to some friends of mine that happened to work with Equifax. Y'all know Equifax is not just the credit bureau, knows everything about everybody on the planet. And I said, we got some great technology. Let us come down and run it across your database and let's see what we can find. Stephen King couldn't have written a more worse story for me because what they found was the worst single database that I had for duplications was our EMPI. We had a 25% duplication rate in the EMPI, and I calculated it was going to cost us $7 million to clean that mess up. Well, I'm no longer working at that facility. So it's someone else's problem. They're going to change EMRs and hopefully they'll clean that up. Then we talked a little bit about the legal constraints and the regulatory pieces. Is that currently the federal government is trying to help us legislate what we need to do in the industry. I think they can be helpful, but I think they're being a little bit too prescriptive. That's my own personal opinion. That $1.75 will get you a cup of coffee at most Starbucks in this country. But anyway, I think some of the stuff they're currently doing, the really nice thing about it is that they're actually listening. How many of you have heard of the Senate Health Committee? Health, ATL Committee, Health, and the last one's pension. I can't think what the other bills you are. Anyway, they had a series of 6 hearings last year. They brought in a bunch of industry experts. They asked for a bunch of information from the industry. And there was a bunch of us that gave the information, a bunch of us testified. It was really nice when the last piece of legislation that came out the Friday before Martin Luther King's holiday was actually very interesting because it actually contained a lot of information that we shared. It was written in a very concise, helpful way. Is it perfect? No. Can we tune it up? They've asked for comments, so we're going to tune it up a little bit. So the good news is they are listening. We've already talked a little bit about constraints. How many of you think that our consent policies that we have in this country work really well? Okay, so the patient comes in your hospital, comes in your emergency room, and you have to call another facility and get records for them. Those records become part of your record, and you send that record with that patient somewhere else, and they share it with somebody else. How can we be assured that that patient's consent is followed those records with them? Can't. We just have to have faith that the patient has consented in all these places for us to share these records. And so this is a place that I had a long conversation with a friend of mine who works for a technology company in Boston. He called me one day and wanted to have a conversation about consent in motion. And I said, what? And after you spent about an hour on the phone explaining this to me, it made a hell of a lot of sense. That's another subject. You know, in Alabama, if you put hell of a lot in front of anything, man, everybody perks up. You know something important's going to come after that phrase. But you know, and I was up, saw him a couple of weeks ago, and I asked him about it. And he said, "Well," he said, "the technology is a little bit too early." And I said, "Well, think about it some more because I think we're getting to the point now we start moving data around. We need to make sure that consent is taken care of." Last but not least is the thing we've already mentioned. It's called data security. The last thing I want to do is I want to make Keith grin because this is actually his idea and I stole it. But I'm going to talk a little bit about interoperability and seatbelts. We've had Aspen, we've had unicorns, now we're going to talk about seatbelts. And no, I did not have a liquid lunch. I have heard that's really great. I appreciate the sound, very good. But let's talk a little bit about seatbelts. How many are old enough in the room to remember in a car, this side of the room, exempt, that did not have seatbelts? It was manufactured without seatbelts. How many of you remember, I want to talk one this time, how many of you remember the outcry and the federal government says, oh, you can't cram your car to your seatbelts? Right? Now, I think all of us will agree, the numbers do not lie. Seatbelts are a tremendous safety feature in an automobile and has saved millions of lives. There was, the other evening, my wife and I were coming up to the interstate, and there was this god-awful wreck. And they finally closed down both sides of the interstate. The top of the car was absolutely gone. The car had crossed the intersection and hit a minivan head on. Everybody in the minivan had their seatbelts on and was okay. They were injured, but they were okay. 5 people in the car, 4 of them died. 1 survived. The 1 that survived had their seatbelt on. The other 4 were ejected from the car. There are 4 teenagers, unfortunately, from the same accident. And so I think that we'll all agree that seatbelts do play a real role in safety on the highway. What the heck has this got to do with interoperability? Well, the thing of it is that what was it that caused us to use seatbelts? What was the one thing I remember when the day the law was passed? If you did not have your seatbelt on your full for stickers, it's going to cost you $75. If you're a pickup truck, that's okay with your seatbelt. Today you do. But so there's very few states, if any, in this country where you can drive a vehicle and not be ticketed for not wearing your seatbelt. It is a law that says you have to do that. How many of you drive or ride in a car without your seatbelt on? Thank you. It's not that I'm going to worry about your health, I'm worried about mine. I don't want you flying through my windshield. So the thing about it is that it wasn't until there was a law that says you will do this that we actually had to do it. The same way with health information exchange. And part of the thing about it is how many of your organizations were exchanging data until meaningful use came along? Well, a few of us were, if you were in Indiana, because we were doing it because we saw value in how it was going to help our patient populations once we got the infrastructure in place. But the grand majority of other places in the country started sharing or exchanging information when they were required to do it, not because they had to, but because they were incented in order to get the meaningful use money, but they were also doing it because now they're being penalized if they're not. Except in 2015, because of the exemptions that were out there, because Congress was a little bit too, CMS a little bit too slow to get the regulations out. So the point about my compare and contrast with seatbelts is that when the federal government first said you had to do it, nobody really liked it. So then they modified it. How many of you remember the first iterations of seatbelts? Not the silent. They weren't very handy. I mean, there were two pieces. Remember the yeah. And you remember the one fold up and the hair up here. You had to do. Then they had I think it was either Toyota or Datsun that actually when you close the door, the seat out. And you're not going to do it without having your car do it for you. So it really wasn't. The first iterations of the seatbelts weren't really good. But I will tell you, the second thing I do when I get in my truck is I put the key in the ignition and I reach back and get my seatbelt and I put it on. When I get in the passenger car, I was in a meeting that was picked up by a driver at the airport. I got the back of the sedan and I put my seatbelt on. And I had to remind him to put his seatbelt on. And I said, you don't mind looking for something. And he looked at me like, why? That's because if you get something, I want to survive the rapids that will ensue afterwards. And so, all right, so I said I was going to leave a few minutes for Q&A. I left 3. So, the questions, comments. Now you want to know about unicorns, aspirin, railroad tracks, and seatbelts, and you can ever really want to know. And I hope that you know how that applies to interoperability.
Can you give us an update how Indiana is doing?
Sure. Currently, Keith, we'll check my numbers. I keep referring to Keith. Keith Kelly is also one of the vice presidents at here in Health Information Sharing. Keith and I have known each other since we were small children, about 20 years. And so we have about 109 hospitals of 116 or so connected in Indiana. We don't connect all hospitals. And some of the things that we're working on right now is we want to get to that next level of interoperability. I don't know if there's anybody here that works in IU Health, is there? Or St. Francis? Okay. What we've done recently is, in order to listen to the clinicians, if you're looking at a medical concern, we can do it with any of them, is when you're looking at the EMR, that patient's record, if you want to know what's in the IMPC, how many of you know what the IMPC stands for? The Indiana Number of Patient Cares, massive clinical data repository, how many 18 million, 14 million individual patients, and we are sitting on 27 terabytes of clinical data. That, as you heard Near talk to you about, we've been loading that database for 13 years. Because it started out with Eskenazi, Wishart Hospital, Clinton McDonald, Mark Overhead, and a bunch of guys that were much smarter than me started loading stuff up. We're supporting several ACOs with clinical data, with care management being able to do population health management. We have a couple of previous sized ACOs around Medicare populations that if a patient is admitted, we give them an ADT report. And so their care managers, and they're also given access to that patient's record, so they can look anywhere that patient's had care. If you're in Evansville, you have 2 places, 2 hospitals, even in the same areas. If you're in Indianapolis, you have a lot of options. And so, if you're responsible for care of that patient, you really need to know where that patient's having care. The same way down here in Evansville, one of the things we can do is give you a view of what's happening across the river, or Henderson and that kind of stuff today. Maybe tomorrow we can do that. So we're looking at how we can enhance and add value to all of the people who use the data. And it's really kind of interesting because have y'all ever gone through the Eskenazi's ER? In the emergency room, the new facility, they have about 110, 112 rooms, keys that right? I think that JT Canal, who is an ER physician there, when I go in, I like to go and tour with JT because the way he uses the data, and he's a practicing ER physician, he only does the tours because we ask him to, is all the physicians in the Eskenazi ER that they were a development partner of the Richard Institute. They have a lot of tools that are now on the market that we're working to put some of those tools out there. One of the things that JT can do is he has a patient that comes into the emergency room. He has a thing that he calls chart search. And what he does, he can put in a phrase or a word, and he has a safe search that says that it's basically chest pain. And in that chest pain protocol, he says, go out and find me the last trauma the patient had, if the patient had an echo, have never had a cancer exam, bring the information back to him, just by typing in chest pain. And he goes like this on it. And so he doesn't have to go hunt for it. He could pull up the IUPC, this massive data warehouse, and he could hunt through, the cardiology data and that kind of stuff. He doesn't have to do that. He can just use his same protocol and pull that forward. And so that wouldn't be great if the system was smart enough to know you were fixing to order that you're about to order an echo, and it just went off and said, okay, this patient had an echo at this hospital. Would you like to see that before? Oh, would you like that to be lifted your EMR? That technology says can do it today, we're going to be working on that. That's the next level of this thing called interoperability. Make it smart enough so we're not having to think. The system is thinking for us, bringing that information to us based upon clinical knowledge, and letting the physicians determine what they, because chest pain for JT may mean something different to a cardiologist, which may mean something different to an oncologist. So that's kind of where we're going. We're sitting on a massive clinical data warehouse, and the way the IMPC is architected is each one of the facilities that shares data has their own data store. I mean, it's separate. It's not mixed together until somebody wants to look at it. When somebody wants to look at it, then the information is pulled together and shared. And then it's also secure. If you're not in one of our participating facilities and we don't know the IP address where your device is connected, you'll never get into it. And unless you have a treatment relationship with that patient, just because I'm in the IMPC and you know that I'm in there, and if you're connected to the IMPC, you can't go look at my record because we don't have a treatment relationship. And so there's a lot of different ways that we can open the doors and lock the doors on that day. Now I'm getting the commercial for the IMPC and I'm really sorry about that. She asked.
How do you determine you have a relationship?
ADT transaction. When the patient is rushed to the emergency room, that transaction comes up with us and unlocks the door. Everything we do, one of the really the things and reasons that I went to the Good Samaritan Hospital wanted to hook up to the Indian Network for Patient Care was one simple thing. It's called total sum. When that ADT transaction hits the servers, about 20 seconds later, this is what we had set up. There was a clinical summary that the patient printed on the ER print that had the patient's most recent admissions, allergies to medications, immunizations. Did they have EKGs online and any other piece of information on one piece of paper? And so really in reality, that physician could have no more about the patient in 20 seconds before they saw the patient. And they can say, I see you're taking, and, there are a lot of physicians, most physicians can infer clinical information. They look at my medication record, they'll say, I see you have high cholesterol now. I see that you've got some cardiac issues, you take some cardiac medicines down. So that's extremely valuable information because you've got a patient that either they may have dementia or whatever. If we can positively identify that patient, which we do about 98% of the time, we'll ship to them 4% of the information. And then the other thing it does is is it opens up the Club of repository so they can look at all the information across multiple locations.
What is the career identifiers, page names, birthdays, social?
There's a whole litany of algorithms